I'm Ryang Chung. I'm an attending physician in medical ICU at Samsung Medical Center, Seoul, Korea. On behalf of Korea, I'd like to celebrate World Delirium Day 2021. Today, I'll talk about ICU delirium study and prevention in Korea. But I'm really focused on finding ways to improve the physical, cognitive, and psychological outcomes of critically ill patients, both in the ICU and after they've been discharged, to try to enhance their recovery process. We conducted a retrospective cohort analysis of the database from the Korean Ministry of Health. Since Korea has a single-payer national health system, the Korean government covers approximately 97% of Koreans. After defining the delirium as newly diagnosed psychiatric cause or who had been prescribed related medications. We enrolled adults who admitted to ICU and no history of psychiatric disorder within a year prior to admission between 2008 and 2015. Finally, 300,000 patients enrolled for analysis. Outcomes of this study is post-intensive care syndrome within 2 years after discharge. Since disability in activities of daily living was not able to define using claim data, we used cognitive and psychological impairment as outcome. Each neuropsychiatric impairment after ICU discharge defined as this slide is shown. All analyses were performed by adjusting for potential confounding factors, age, sex, comorbidities, medical beneficiaries, region, mechanical ventilation, ECMO, CRT, vasopressor drugs, quality of ICU, and ICU length of stay more than 7 days. We calculated the hazard ratio with 95% confidence intervals for developing each peaks using a proportional hazard regression model. The mean patient age was 58.3 years old, and 64.5% of patients were men. The proportion of patients with delirium was 55%. The number of patients with comorbidities and patients who received mechanical ventilator, ECMO, CRT, vasopressor drug were higher in the patient with delirium group. In addition, patients with delirium had a longer hospital length of stay and ICU length of stay than patients without delirium. The readmission rate was more frequent with delirium group. The hazard ratio for readmission in patients with delirium compared to the patient without delirium was 1.22. Adjusted hazard ratio remained significant. The risk of incidence of cognitive impairment was higher in patients with delirium. Furthermore, patients with delirium also had increased risk of psychiatric impairment after discharge compared to the patient without delirium. Compared to the patient without delirium, the patient with delirium were 7% and 63% higher risk of readmission and psychiatric impairment after discharge. In this figure, we could find the risk of readmission, cognitive, and psychiatric impairment were higher in delirium group. In terms of economic outcome, the in-hospital medical cost 26% higher in patients with delirium compared to the non-delirium group. After discharge, patients with delirium used 15% higher medical cost than patients without delirium. Furthermore, psychological problem-related costs were much higher in patients with delirium than non-delirium group. Summarizing the first study, more than half of the population had delirium during ICU admissions in Korea. Our study suggests that delirium during ICU admissions may affect mental health and cognitive disorders development within 2 years of ICU discharge. Accordingly, we should pay attention to ICU delirium prevention to improve the neuropsychiatric outcomes. I will introduce another study for predicting ICU delirium with machine learning-based modeling. We include the patient who are negative CAM-ICU at the time of ICU admission and externally validate with mimic3 dataset. This figure shows training and internal validation and external validation code flow chart. A comparison of the performances of all of the models is shown in these tables. The best model for the internal validation was XGBoost with an AUROC of 0.919. For the external validation on the mimic3 database, the model with the best AUROC was the random forest model with an AUROC value of 0.721. For the external validation with mimic3, we only selected variables that could be found both in our hospital and mimic3. As a result, only 59 variables were selected. The variables were categorized into general information, flow sheet, laboratory test result, and prescription of medications. The most important variable was the use of invasive mechanical ventilation in general information. The variables importance of the final variables used in model development is shown in this figure. Summarizing the second study, we have developed and validated the PRIDE delirium prediction model, which can predict the occurrence of delirium within 24 hours of ICU admission using clinical data obtained in the first 4 hours after ICU admission. This model has acceptable AUC value and sensitivity, thus it has the potential to help to advise ICU physicians and prevent ICU delirium. So how can you set up ICU delirium prevention program in our ICU for overcoming the post-intensive care syndrome? In order to prevent ICU delirium, the critically patient must be kept awake and be able to obey commands. Therefore, firstly, we need to make an analgesic first sedation protocol for the light sedation. As you know, as the protocol production itself did not change the medical staff patterns of sedations, repeated training and feedback were provided to both ICU doctors and nurses, and then we can enhance the compliance of ICU sedation protocol. I'd like to emphasize a stepwise approach for establishment of ICU delirium prevention program, ABCDE. ABC is bundle approach, and then finally you can achieve the goal of delirium prevention. This is called ABCD bundle approach. For maintaining a quality of ABCD approach, we have been having a monthly-based meeting for sharing each metrics. Every champion prepared their metrics and discuss about the monthly outcomes each other. For example, we share the prevalence of sedation status, such as RASS, the trends of RASS score, which is improving or not, and sharing MICU error counts by MICU champion nurses. This kind of activity enhances the nurses' participation and interest by themselves. Through several years of steady effort like this, we have found that the rate of delirium is decreasing year by year. After finishing the foundation frame of ABCD, finally you can achieve E, early mobilizations. After setting up a multidisciplinary ICU rehab program, and we could find positive results such as decrease of ICU length of stay by 1.2 days and hospital length of stay by 6 days. For this work, teamwork is the crucial element for implementing a successful ICU delirium prevention and rehab program in your ICU. To summarize my presentations, to prevent delirium in ICU, by stepwise ABCDE bundle approach with self-motivated by every individual step in your ICU, not by reader only. There was always unpredictable barriers, but we should keep in mind consistency and team spirit. Thank you for your kind attention.